All right, my perimenopausal ladies, we've kind of left you out. We talk about you when we're talking about hormones, but menopausal women have been getting so much more attention. And listen, I'm thrilled about it. There are 5,000 menopause books out. Halle Berry's talking about it. Oprah's talking about it. We're getting focused finally on women's health and menopause. But what about that time right before? What about that really confusing time called perimenopause that we don't know when it starts? We don't know when it ends. We don't know what to do during it. So that's why I'm bringing on a very special guest, Dr. Amie Killen. And if you've not heard her, listen, Amy, I follow you on social. And I got to say, every time I watch you, I'm like, she's so much like me. So this woman is blunt. She's funny, and she's going to break it down for us today. So if you haven't followed her yet on social, of course, we'll talk about it at the end, put everything in the show notes, but you got to follow Dr. Killen because she's just amazing at the information she puts out there, and she does it with such great humor. So I love it. So Amie, welcome to the show.
I have a good time on social media. It's not always well received, but I have a great time. So
well, people don't like it. They don't have to look.
that's
Scroll
true.
on.
It's
Scroll
true.
on. But,
Yes.
I mean, the way that you bring information to the masses, I think is on point because we need some humor when we're talking about hormones. We need some humor when our vagina is drying up and we're hot flashing and we don't know what to do.
Yes.
So I appreciate that. And I'm sure the women do too.
Thank you. Thank you. Well, I'm excited to talk about perimenopause because I agree it's one of those things that doesn't get talked about as much. In fact, I was just responding to a video I saw of a woman saying that perimenopause wasn't real. It was all a marketing term that was invented in the 1980s to sell hormones.
Oh my, what is this woman, 25? Like, has she gone through lots of hormones
No,
yet?
yeah, it was so. I mean, she's about 40. I think she just tried to sell something else. I'm not sure, but
Probably.
I have a good rebuttal coming for her soon.
That's good. That's good. I want to watch that happen. But we do see a lot of that out there. That
Yeah.
there are many practitioners recently. You commented on this, and then I had a side comment with a group of women about this. One practitioner in particular, who is a male, who basically is standing on stages saying, "Y'all don't need hormones, just fix the cell." And it's like, okay, I get it that there can be cell issues, but if you have not been in a woman's shoes and you have not lost those hormones as we age, you can't be up there telling women to avoid hormones. You just
Yeah.
can't.
Yeah.
Yeah. Yeah.
Well, and
So
I think that there's always a thread of truth in all of these different people who have opinions about midlife women. Certainly, we do have to pay attention to lifestyle. Certainly, we have to dial that in. We do have to pay attention to our mitochondrial health and all the things. Like those are all important. So I think that hormones are not going to solve all your problems, but I also think that they're part of the conversation that every woman deserves to have with her doctor. And unfortunately, 95% of women are not able to because their doctors either don't understand it or have some misinformation about these, midlife hormones.
that's so true. That's so true. Okay, we'll get to hormones. We're going to bring those in. Perimenopause. Let's just start at the beginning. When does a woman know that she is in perimenopause? Do we look at labs or do we go by symptoms?
Symptoms are more reliable, and I am a fan of lab testing for sure because, even in a normal cycle, your estrogen and progesterone are going up and down depending on kind of where you are in the cycle. But at least then we can test on a certain day and say, okay, we expect progesterone to be in this range, but you're not or whatever. The problem with perimenopause is the cycles can become erratic and you're also not always ovulating. So now, your estrogen may be 20 or 30% higher some days and then it crashes down other days. Progesterone's not playing by the rules. And so if we check those hormones during perimenopause, we may get, various degrees of craziness, but really what tells us that you're in it usually is symptoms.
Okay. So what are those symptoms? What can a woman look out for where she knows, yeah, she might be entering that stage?
Yeah. So, usually it's about between 2 and 10 years before menopause. So that can be a pretty wide range, of time there. There are about 30 something different symptoms. And I just did a post on this and I had everyone just comment on their symptoms that they were having. It's like the first symptom of perimenopause. Like for me, it was joint and body pain. Waking up in the morning, I'm 49, waking up in the morning with just like, I felt like I did a seriously hard workout the day before, but like I hadn't, every day. it was like that. And so that's a pretty common one. Body pain, difficulty sleeping is very common. Anxiety, panic attacks because of progesterone going down. Certainly vaginal dryness, loss of libido, weight gain. It could be weird stuff though too, like itchy skin or dry eyes, or it's all over the map, which is what makes it so difficult.
Well, yeah, I mean, it sounds like that it is all over the map. So it's like, whoa, I have every symptom in the world. It could be perimenopause. It could be
Yeah.
thyroid. It could be loss of, it could be all these different things.
Yes.
Okay. So woman has set of symptoms. And it's funny. I always say the first sign of the loss of progesterone is when your significant other or people around you say, why are you being so bitchy all of a sudden? And it
Yeah.
seems like that's the first, but it's very interesting that you got the joint pain, because isn't that usually more associated with the loss of estrogen? So it would be more down the road in menopause.
Yeah, you would think that. That is true. It usually is a little further. So usually in early perimenopause, like you're saying, early perimenopause, usually progesterone is starting to go down, but estrogen's still relatively high. And it's that discrepancy between estrogen and progesterone that causes a lot of symptoms. And then as you get closer to menopause, sort of late perimenopause, is when both estrogen and progesterone are going down. And you'll have symptoms of low estrogen as well. So you're totally right on. But I think this just kind of tells us that, unfortunately, not all women read the rule book in terms of symptoms and when they happen.
That is true. That is true. So progesterone really is the first hormone to tank, or would it be testosterone? Or are they neck and neck?
Yeah, well, testosterone is going down gradually starting at about age 25 or 30 for both men and women. So it's kind of a slow march downward. It doesn't fall off a cliff though during, at age 45 or 50 like estrogen and progesterone do. So some women they are 30 years old and have low testosterone, especially if they're taking birth control or something, and they benefit from testosterone. Some women never need testosterone because their body makes enough of it. So testosterone is a little different in the way that it behaves. So it could be either progesterone or testosterone could be the first ones that go down.
Okay. And then the symptoms of the declining testosterone, what will women notice there?
The biggest thing I see is lack of motivation. That is something that isn't talked about a lot, but like lack of motivation to get off the couch and go to the gym, or to like go out with your friends, to do something that requires some effort. But also we see, lack of libido, difficulty with arousal and orgasm, sexual kind of stuff. We'll certainly see difficulty forming muscle and difficulty burning fat, because that's, anabolic hormone. But, even brain fog or depression, like there's so many things that testosterone can also be associated with. So it is a little tricky sometimes to figure out. Luckily, we can test testosterone pretty easily. It's relatively stable throughout the month. So that is one hormone that I always check. And the other thing, I always get labs, because you still do want to rule out everything else. Make sure the thyroid is okay. Make sure that, that all your lipids and everything else is okay, because those things will also be affected oftentimes during this transition.
Okay. So where do you like to see a woman's total and free testosterone? What is optimal for you?
So in general, I pay more attention to free testosterone than I do total. I like it to be kind of middle to upper end of the reference range for her lab. And people always say, well, what's the reference range for my lab? But unfortunately, especially with free testosterone, there's a lot of variability between labs. So the easiest way to do this is to Google whatever your lab name is, LabCorp, and then just say, testosterone reference range for women. And then you'll get what that range is. And generally kind of being towards the upper end is usually better.
I say too. I love that. Okay. Beautiful. I say, yeah, at least halfway, if not that upper half. I love that. Now, progesterone. Okay. So we normally, and correct me if I'm wrong, we normally test progesterone in a cycling woman, phase 19, 20, 21 of her cycle, in that luteal phase.
Yes.
Where do you like to see the progesterone level of basically a non-perimenopausal woman? Where is that hardy number? And then what will we start to see as a woman goes into perimenopause? What will those numbers do?
So, the women's progesterone is usually between about 5 and 25 nanograms per liter. I always forget that, but about 25 is usually the top, and then it kind of goes down. Everyone's a little different, and certainly the labs also have changed how they're measuring progesterone. So we have new assays that are a lot more specific, which makes it difficult. But somewhere in the upper 15 to 20, 25, somewhere in there is ideal. You're at like 5. in the mid-luteal phase, that's definitely not high enough.
Okay, that's where I was going because there's so many times where I will look at a woman's labs and she's cycling regularly, every 28 days, looks great. But we look at the progesterone, and I'm like, this is only like a 3, a 5, maybe a 7.
Yeah.
It's not good enough for me right here. So I love getting your opinion on this too, because this is
Yeah.
your jam. Yeah.
And we see low progesterone, certainly in cycling women, certainly, even 25-year-olds, 30-year-olds, because progesterone is so sensitive to other things. It's sensitive to stress. It's sensitive to if you're overtraining. There's all these other things. Obviously, polycystic ovarian syndrome, they don't make
Yep.
enough progesterone. So there's a lot of things that can contribute, both lifestyle factors as well as other things, to low progesterone. And, you can cause symptoms, it can cause PMS, but it can also cause infertility if you have low progesterone. So I think it's worth checking, especially if you're having symptoms, even in cycling women.
Now, I'm going to pick your brain on HRT and the use of and when we started and all of that. But with when you're looking at that progesterone level of a cycling woman, or even, I'm sorry, even a progesterone level of a perimenopausal woman where her cycles are all over the place. She has 2 in 1 month, then she skips 3 months, then she has another one. So when you're looking at that number, when it starts to decline, I guess at what point do you say, okay, time out, it's time to bring in some progesterone hormones, some bioidentical progesterone into your body?
So if she's in perimenopause and is having irregular periods, I don't even wait for the number. I think that if you have the symptoms and you're in perimenopause, we can start progesterone. And
Okay.
the reason I say that is because, the number might be 20 one day, but it also could be 3 the next day. There's not a lot of rhyme and reason. And so using a single lab test to say that you do or don't need hormones in perimenopause, I think you're leaving out a lot of women who could benefit from progesterone.
Yeah, I completely agree. Okay, wait, now I have to stay on the HRT topic because this is too good. So you're 100% right, and I think too many doctors, well, especially conventional, as we know, will say, "Well, you don't need hormones right now because you haven't stopped your cycle for 12 months. Once you are 12 months into menopause, then maybe we can talk." And then normally they're talking about progestins anyway. So,
Yeah. Yeah.
so, I love hearing from you that we can start progesterone just based on symptoms. Now, let's say we start that. Do you like to cycle the progesterone if a woman is still cycling, or what are your thoughts on using it every day of the month?
Yeah, great question. In general, and everyone's different, if the woman is cycling regularly, I generally will cycle the progesterone because we want to just mimic. We want to kind of support her own production and just mimic it. So essentially giving it like during the luteal phase, so maybe day 14 to 28 of her cycle. I will say that with a caveat, which is that some women love progesterone so much, they get on it, they're sleeping well, their anxiety's better, their migraines are better, they feel great. And sometimes we'll do a daily progesterone, but then we'll increase the dose during that luteal phase. So maybe it's 100 milligrams on day, 1 to whatever, 14, and then we increase it to 200 the second half. So we still have a cycle going, but she's getting a little progesterone every day. So there's a couple of ways to do it.
Okay. Yeah, and when you have women that love the effect on their sleep, it's so hard to tell them to take a break. Now, is
Exactly.
there anything to because I've heard some practitioners talk about taking a hormone holiday from progesterone, even if it is 2 days out of the month, or, take a hormone holiday just on the weekend. Is there something to that? Because that seems like a very big debate in this perimenopause, menopause hormone space.
Yeah. Well, there is a lot of debate, and there are some practitioners certainly who believes, very, very strongly that you should be cycling progesterone even in menopause, that there's the receptors and all these things.
Right.
The truth of the answer is we don't know. We don't have any good comparison studies that tell us in menopausal women that you should or shouldn't cycle, or that the receptors need a break or don't need a break. So I think it makes sense. If you're going to take a break, it makes sense to take it when you start your period, because progesterone falling is the signal to your body that it's time to shed the uterine lining. So if you want to mimic nature, then stopping progesterone during your period is probably the most important time to stop it. But again, some people do find not stopping it.
Okay. Now, what about those poor women that are getting 2 cycles a month? What do you do? Do you just tell them, okay, for that second one, go ahead and just carry the progesterone all the way through, or do you have them stop it again?
It's kind of a trial and error. I mean, some people, I'll just put them on progesterone every day. Like if you're having a lot of irregular cycles, just crazy irregular, whether it's because of perimenopause or PCOS or anything like that, then I'll just usually just do a daily progesterone, and just like not pretend like I'm even trying to get it back on track that way.
Okay.
But if we can get it back on track, certainly we will. It's just not always possible. And it's so hard for women. Like it's hard for me. And I know all this stuff to be like, well, what day of the month is it? And am I supposed to take it or not take it? And, like, what's the dose? So I try to keep it as simple as I can so that they actually, take the medicine.
Yeah. Yeah. And then when you're brain foggy and you're not sleeping, then simple
Yeah,
is better anyways. Simple is better.
exactly.
Now, I'm just going to take a little bit of a turn off the road here, because since we're talking about hormones and the receptors, what popped into my mind, and I heard you talking on a friend of mine's podcast, Stephanie Estima, and you were talking about something that comes up in my practice a decent amount of time, at least enough to have this discussion. When a woman is in menopause and she is 10 years plus without hormones, but
Hmm.
she wants to start on the hormones,
Yeah.
what can she expect? So basically, I would love to know from you the protection. Like, is she getting any of that bone, brain, breast, heart protection 10 years after? Can we at least give her symptom relief if we start hormones 10, 20 years down the road? And what do we have to be aware of when we start those hormones? Because those receptors are so, they're basically dried up, but they're also kind of like sponges, and they kind of, I overabsorb is completely not the right medical term whatsoever, but I see these women over respond to the hormones.
Mm. Yeah, I mean, I think the first question is, can women take hormones if they're more than 10 years out from menopause onset? Because the classic teaching was that they probably shouldn't because there's too much risk.
Yep.
That I think has gone out the door. I mean, the increased risk came from starting synthetic hormones, progestin and Premarin, more than 10 years from menopause onset. And that did have some problems. But the hormones we use now, the bioidentical hormones, there's not a lot of increased risk, especially if it's transdermal estrogen. Now, as far as benefit goes, the systems that are still very responsive to hormones are your bones and your pelvic floor, for sure. So those things, we definitely still see benefits with hormones, even if you're 65 or 70. The systems that maybe aren't as responsive to late start hormones, at least per the studies so far, are the cardiovascular system and probably the brain, the dementia benefits. We know at the heart, we know for sure that if you start hormones more than 10 years from menopause onset, or once cardiovascular disease has started, like you already have atherosclerosis, you already have plaque in your arteries. If you do that, we're not going to prevent or further prevent heart disease to any degree by starting hormones in those women. So it is important to know, and it's important to start early if you can, but obviously a lot of women, unfortunately miss that window.
Right. Right. And they do. I mean, there's been so much misinformation out there for years, but at least they know that there's going to be some benefit they get out of it. Now,
Yeah.
what have you found when you start hormones on those type of women that have been so deficient for so long? How do you see them respond? Do you see the hyper response or the slow to respond?
Yeah, no, they can definitely be. I usually start the dose lower than I would for anyone else,
Yeah.
because they are going, their bodies are just not used to these hormones. For instance, you can certainly have vaginal bleeding, and that's fairly common. You start estrogen later on, all of a sudden you've got this 65-year-old and she's bleeding, and I know everyone's freaked out because she's bleeding, which I understand, but that's your kind of just your igniting or turning on some of those receptors that haven't been on for all that time. So I do start lower and I go slower with the women who have been off hormones for a long time. Yeah, just like
Yeah.
you said.
Yeah, exactly. Exactly. Okay, I had to go there. I had to get your take on that. Now we'll take it back on the road to perimenopause. Now, you talk about a perimenopausal glass ceiling. I've never heard that term before. You got to break that down for me.
Yeah, I mean, I don't even know if it's a real term, first of all, but I did talk about this because I was talking to a friend of mine, Carla Vitrone, who has this company, and she was talking about how in the kind of corporate America, she's in New York, that she feels like that perimenopause is really contributing to this glass ceiling that women have. So I started doing some research on it, and I do think that there's something there. I mean, we know in perimenopause that the brain is essentially your brain energy dims by about 30% as you're going through perimenopause. And so like you're trying to do the same things you could before, but now you've got, difficulty concentrating and can't find words and I can't focus for very long and, like I'm distracted easily. It's from that. And then you also lose testosterone, which I think is very problematic, especially for women who are in leadership positions. Testosterone gives you the confidence, it gives you motivation, it gives you assertiveness, and all of a sudden that goes out the door. And it's like you can't make decisions very quickly, and you're unsure of yourself, and your leadership style completely changes. So we know that, like, I don't have the numbers on top of my head, but it's like 30% or something of women kind of step back from like their job. Maybe they don't necessarily leave it, but they step back from challenges and new clients and leadership positions during that kind of menopause transition.
Yeah. I know, and that's so sad because these are powerful, badass women
Yes,
that you
yes.
almost see them diminish. Now, let's say those women were to catch themselves and start on hormones early. When would they start to see that motivation and that brain shift occur? How long does that take?
Now, on testosterone, it can be as early as a few weeks. I mean, I tell people to give it at least 3 months with testosterone for the motivation, assertiveness, that kind of stuff. Certainly, estrogen is going to also help turn that light bulb back on. That's really important. But any of these changes can sometimes take a few months. You got to kind of like give it some time, let it settle, and then be ready to make adjustments to either your dose or your, route, your delivery system, because this is more of an art. It's an art and a science, I guess, but everyone responds differently. And so what works for your sister or your mother may not work for you. So you have to be ready to be like, okay, I'm going to go on this like multi-year exploration of trying to feel as good as I can with, the hormones and everything else that you're doing.
Now, you're a proponent of starting the hormones early, like before you lose your cycles, before the symptoms take over your body, right?
I am. Yeah, I am. I think progesterone for sure, early
Yep.
testosterone if you need it. And then estrogen, we used to say you got to wait till you're 12 months from periods, like you just said. But, we also know that the bone loss, for instance, that happens in perimenopause can happen, 2 years before you have your periods become irregular. And so if we're trying to prevent some of these things that from happening like bone loss, then it makes sense to potentially start even estrogen a little bit earlier.
That's a great point. Now, when would you actually start the estrogen? Are you looking there at symptoms or a DEXA scan for the bone, or are you looking at labs and actually looking at that FSH and the estradiol number? And at what point do you say, okay, I get it that your cycles haven't stopped, but it's time here. It's time
Yeah.
to add in the E.
There's a couple of ways to look at it. I mean, there's a couple of tests. So certainly FSH, that'll start to go up, as you're getting closer to menopause, because that's your brain. It starts to yell louder at your ovaries that we need to make estrogen. So that starts to trend up, and that is something you can follow. I also like tests like the glycanage test, which is a test it's essentially measuring a special kind of inflammation attached to your immune cells, and we see that glycanage go up like significantly, like maybe you age 10 years on that test in, a 6 month period when estrogen overall has started to drop, even if there's some fluctuation, during certain times of the month. And then there's also I'm actually an advisor for a company called Timeless Biotech, and they're coming to market pretty soon with a menopause predictor that essentially uses AI and a couple of different basic labs to predict when you'll be going into menopause. And they can predict it out 12 years into the future. So that's something else. It's not expensive. Maybe you're 35 and you're like, I have no idea if it's going to be like 2 years or 15 years. So apps like that can be helpful as well, or platforms.
Okay, interesting. So just for the listeners, there is no harm in starting estradiol or an estrogen replacement, bioidentical hormone replacement. Maybe you do a bias estradiol. There's no harm in starting that before your cycles stop.
That is correct. There's no harm. The only caveat is to know that your endogenous, what you make estrogen production is about 20 to 30% higher in early perimenopause than it was when you were in premenopause. The peaks are higher. Maybe before your estrogen would peak at 400 and now it's peaking at 800. And so we don't want to give you a lot of estrogen on top of that if if you already have too much estrogen. Wait until the symptoms are telling us this, as well as maybe some of those lab tests.
Yeah, yeah, absolutely. Yeah, because a woman could go into a pretty significant estrogen dominant state because of the low progesterone as she is moving through perimenopause into menopause.
Absolutely. And a lot of the symptoms that we think of, like hot flashes, for instance, that can be from, it's not always low estrogen. It could just be chaotic estrogen. So changes in estrogen. So usually we start with progesterone because oftentimes that actually will help with even things like hot flashes in perimenopause because it's not all about the estrogen.
Yeah. Yeah, exactly. And a lot of women don't know that either, that progesterone can actually help with the menopausal quote unquote symptoms,
Yes.
that they automatically they immediately tie hot flashes or vaginal dryness to low estrogen. It's
Right.
like we've been taught that, we have that in our minds, but not realizing that progesterone plays such a significant role as well.
Yeah, and I love it. Progesterone is so safe. Like I love it. It's such a great medication. It's extremely safe. It's very it's calming. Not everyone loves it. Certainly there's, 10% of women or so who don't love it, but in general, I think it's such a great medication.
Now, do you ever find with progesterone that some women don't do well on the oral? There's that small percentage that they get almost the opposite reaction. They'll get anxious and just
Yes.
not tolerate the oral.
Yeah, absolutely. About 10% of women will have either a paradoxical progesterone response, which is essentially instead of being calming and helping with sleep, it causes excitation and anxiety and they can't sleep. That's one thing that happens. And then the other thing that happens is that some women are just very sensitive to the progesterone. So like instead of making them a little bit sleepy, like they're waking up groggy the next day and they're depressed and all of those things. So either of those though, if we give it a non-oral form, so you don't make the metabolites that then go to your brain, like a vaginal progesterone, for instance, or a troche under the tongue, people tend to do better.
Okay. That was going to be my next question, is then the option for those individuals that respond that way, cream, troche, vaginal, all of that.
Yeah.
Now, why is that? Why is that? What happens with the brain? Because I want my listeners to understand this. What happens with the brain when someone does not tolerate progesterone orally? They have that paradoxical effect.
Yes. So when you take any medication by mouth, like you're swallowing a pill, it's gonna go through the liver before it gets into your bloodstream. So it's called first pass effect. We know about this. Some people think, talk about it being really bad. It's not bad. We just got to understand what's happening. So the progesterone goes through the liver, it gets made into metabolites, and one of those is called allopregnanolone. And that metabolite actually goes to your brain and it acts on your GABA receptor. And you think about GABA as being like calming and relaxing and all of those things, which is why for many women, progesterone is so great. It acts on GABA, it's very calming. Some women have they think it's actually a GABA receptor issue where the receptor reacts the opposite way. So progesterone binds to it, but then the downstream effect is essentially excitation. And oftentimes the women who have that, some of them also had like PMDD, for instance, where they would have difficulties during the second half of their period, of their cycle, with anxiety and stress and dysmorphic disorder. And that we think is also a GABA receptor issue. At least partially.
Okay. And there's nothing that they can do to shift that. They just have to deal with the fact that, okay, you might not get the sleep benefits from the oral progesterone, but you're still getting all of the benefits of progesterone through the cream or the troche. Yeah.
Yeah, exactly. I mean, as far as I know, there's not an easy way to shift that. I haven't found it yet, if there is.
Now, what about pregnenolone in perimenopause? Do you use that a lot?
I don't use it too much, although I think there's a use case for it. We think of it as being like the mother hormone. I tend to like to replace like very specifically the hormones that I can see that are like, lost. It's same thing with like DHEA, which I do use, but some people will use DHEA to instead of like testosterone because it gets made into testosterone, but it also
Mhm.
can get made into estrogen. So for me personally, if I want you to have testosterone, I'll just give you testosterone.
Yeah.
But having said that, I think that there's probably a place for some of these hormones. It's just a little bit tricky to know what your body's going to do with them, when we give them to you.
Right. Right. And now I've seen a lot more lately on pregnenolone's protective effect on the body from cancer.
Mm.
And I've been listening to obviously, I mean, gosh, you were actually on stage with me at HOS when I kind of announced, I'm like, yeah, I just literally yesterday got a call that I have uterine cancer, but it's cool. We're going to talk about hormones today. But I've obviously been going down this rabbit hole of how protective progesterone is and
Mm.
how protective pregnenolone is. So I've been incorporating more pregnenolone, but I want to come back to you and ask you about progesterone's protective effect on cancer being anti-proliferative. So we talked a
Yes.
lot about the connection with the symptoms, and then of course fertility and infertility, and even thyroid and insulin is helped by progesterone. But what about those cancer protecting components of progesterone? Can you talk about that?
Yeah, there's a lot of debate still in the medical literature, I will say. Like for instance, thinking we know that progesterone protects against endometrial cancer, uterine lining cancer.
Right.
That's not even disputed. But there's a lot of debate on its role in like breast cancer, for instance. I really think that most of the literature points to it as being very protective for against progesterone. I think of estrogen as being kind of like a construction worker. Like it's very anabolic. It's building up tissues. It's building. It's protecting. It's building. It's building, and it's great. But then I think of progesterone as being like the project manager on the scene. Like it's making sure that estrogen is not building too much or in the wrong places. Like it's kind of like keeping things in a safe level. And so I use progesterone with all of my women who are in menopause, whether they have a uterus or not. I think it's really important to not just protect the uterus, but also, we're going to protect the brain and the heart and all the different things, the breasts. So I think it's important. And I think that eventually the more traditional doctors will start doing that. But they haven't yet. The guidelines still don't recommend progesterone, unless you have a uterus.
Well, it's wild too because I had mine taken out, and I would never give up the calming effects of progesterone, the bone protection, the
Mhm.
sleep, the mood, the dot, on and on.
Yeah,
It just blows my mind that we're still in this mindset of like, oh, well, you don't have a uterus, so you don't need anything else. Like, you don't need that
it's
sleep
crazy.
help or, oh
No.
my.
I mean, we know that sort of yin and yang relationship between estrogen and progesterone. Like it's very clear, it's very known. And we know that progesterone, even affects the way estrogen binds to the receptor. Like there's so much, like those things should be a pair. And so the
Uh-huh.
idea that we're just going to give one without the other one just because you don't have one organ, I think it's just crazy. It's crazy town.
It is, it's so crazy, and I mean, we always talk about everyone in this space talks about you should never take estrogen unopposed, meaning you don't take estrogen without progesterone. Like, just like
Yes.
you said, they go hand in hand, they're a pair.
Yeah, the only time that I say that it's okay or that I recommend it is if you're doing like a low dose vaginal estrogen.
Mhm.
And in that case, which I recommend every woman, if you're over 50, if you're not taking a low dose vaginal estrogen or, something else like a DHEA or testosterone to help the pelvic floor, get that from your doctor is inexpensive. It saves lives. But that one you don't need progesterone because it's a locally acting. It doesn't get, in the rest of your body very much. It's a very, very low dose.
Right, it's not gonna have those growth promoting properties like an
Exactly.
estrogen. Yeah, yeah, exactly. Okay, I have to ask you, what is the queen phase of perimenopause?
I think of the queen phase is essentially when you when you lost your own hormones, like you
Yeah.
lost estrogen, progesterone, those have gone away. That protection, that shield that they provided you has gone, and now you have to kind of step into protecting yourself. So it's this you're putting on your crown and you're saying, you know what, I'm not going to rely on I'm not going to rely on other things to protect me. I'm going to do it myself. So it's whether it's taking hormones and getting a prescription, but also, lifting heavy weights and making sure you're building muscle and like essentially taking on that protective role for yourself versus relying on, it to be already there. Because before we lose those hormones, they're there invisibly protecting us and shielding us, and we don't know it, but we kind of just have to, we benefit from it, but eventually those hormones go away.
Oh, I love it. Well, and I will even say there is a Queen 2.0 phase. So wait, Dr. Amie, you're not yet in menopause yet, right?
No, I'm
Right.
49. I'm pretty close though. My cycles have become sparse. I feel like I'm like basically there, but I still say I'm in perimenopause.
Okay. So, yeah, I don't know whether this occurs at the age of 50 or if it just occurs in menopause. So, whenever you enter, but I'm going to say the Queen phase 2.0 is it's very much what Lisa Mosconi talks about, where that armor, because you said armor, so that's what made me think of it. That armor kind of falls down, and you literally do not give a shit about anything anymore. You don't care what people think about you. You don't care about going to the grocery store without makeup on. You don't care about the little things that used to bother you, maybe in perimenopause, don't. So
Mm,
that's one thing that you can look forward to, and you can
I
totally
love it.
coin the Queen Phase 2.0 if you'd like.
I love that. Yeah, I hear a lot of women talk about that. Like it's just like all of a sudden, like you just don't care as much about all that stuff, which is great. I think that's awesome.
Fantastic. So perimenopause is setting you up for that. Just like Dr. Amie said, like you're getting ready, you're lifting heavy, you're putting yourself first, and then you're just going to move into this other beautiful phase where people are not going to annoy you as much anymore.
Yeah,
Something to
because you
look
just don't
forward to.
care. I love
No, you
it.
don't care. You don't care. Is there
That's awesome.
anything I missed about the beautiful stage of perimenopause that we needed to touch on?
I think the most important thing is know it's coming. Make sure it's hard. It's hard always to find a provider, like medical provider, to help you. But I think it's so important to have someone who's kind of like your co-pilot that helps you to know what's happening, to explains the process. Tells you it's going to be chaotic, but eventually it'll settle down. Because there's so many symptoms, and it's a lot of people will see 4, 5, 6 different doctors with all these crazy symptoms. They'll see a cardiologist and a neurologist and a rheumatologist, and like it really is all from one thing. So finding that person to walk you through it is so important if you can.
And just knowing that you're not crazy, it's just your hormones. You're not losing your mind. You don't need
Yes,
to, you don't need to kick all the kids out and your husband too. So,
exactly, exactly. It may look different for you than anybody else in your life, and that's okay. And you will get through it, but hopefully with some support.
yes, yes. Yeah, the support is key. So on that topic, Dr. Amie, you do so much. You do so much for so many people. And I mean, really, you're a crazy entrepreneur. So where can people find you? All the different websites. What are all you doing these days?
Yeah, so I'm on Instagram, Dr. Amie B. Killen, and that's my kind of primary social media, but I'm on all the other channels too. My website is dramiekillen.com, and I also have on there kind of my links to my different companies. I have a longevity clinic franchise called Humanot Health, which we just launched last year, and that is humanothealth.com. It's in Austin, Florida currently, and we're going to be expanding that. And then I also have a female-focused longevity supplement company called Hopbox, and that's super fun. It's kind of like all my favorite supplements into one little pack, and that's at hopbox.life. So those are some of the places that you can find me.
I love it. And we will put all those links in the show notes of where to find Dr. Amie, but you got to follow her on Instagram because she's amazing. So I'm just saying. So,
Thank you.
Dr. Amie, thank you. Thank you so much for joining me on here. And this is a beautiful podcast, just breaking it down for all my perimenopausal ladies out there.
Yes, thank you so much. This was so fun.
Absolutely. We will see you soon.
Awesome.